where he spent 35 years as a math professor, served as chairman of the faculty, and was instrumental in establishing science, biology, chemistry, and engineering departments. For UVA, he was best known for increasing student interest in astrology. He served as a committee appointed by the board to obtain a large refractor telescope for the McCormick Observatory. At that time, it was the largest refracting telescope in the world. He died in 1900, buried in the UVA cemetery, and his family requested that this be established for a trauma lecture. Adam Fox, our guest, I've known Adam for well over a decade. He's associate professor and trauma director at the Eric Munoz Trauma Center in Newark. He's chair of the New Jersey Committee on Trauma. He's medical director of their medical program. He joined their faculty in 2011. He had previously practiced at the University of Pennsylvania and Penn State. Instructor and course director for multiple trauma and critical care courses. He's an active member with me of the trauma critical care team, the National Disaster Medical System, and we've deployed several times together previously. He also does a great deal of medical mission work and disaster work worldwide. Provides medical direction, care, and education to the Newark FBI SWAT team and other law enforcement agencies. On the editorial board of several journals, well published, and he's had leadership positions in trauma education, global disaster, medicine. He was also on several episodes of New York Med. Adam, I've known him a long time. We've deployed to the COVID trenches and June of 2020. He's really is considered a national expert on disaster response. I'd like to welcome him.
Thank you, Jeff, for the kind introduction. Thank you, everyone here, for inviting me. My talk today is a little different than some of the other talks that you usually hear because we don't really focus on disasters very often. Although as surgeons, a lot of times, especially trainees, you're going to be involved in seeing multiple patient events or mass casualty events. And there is an increasing recognition that there is a need for an understanding about how disasters work and how mass casualties or multiple patient events work. So the title of this talk is a primer and case for surgeon involvement. I think that surgeons do need to be educated and involved. That's biased, obviously, but I have other. Okay, all right, cool. Thank you. I have another couple of title slides. Disasters and mass casualty events. It's not just for emergency medicine. No offense to anybody in emergency medicine who may be sitting in this room. Emergency physicians have taken a great lead on doing disaster management. I think surgeons just haven't done enough. So it's not just for emergency medicine. And then the last one, last title slide I have is, it's kind of cool in an academic way. You never want to really be involved in a disaster, but the fact of the matter is, if you either deploy or have to deal with it and you do reasonably well, it's very cool. This is me dangling out of the back of a Chinook after an exercise with the Air Force, a patient movement exercise that we did around Seattle last year. That's Mount Rainier, and my feet crossed in the back of the Chinook dangling out of it. So I have a good time. Just a quick disclosure for myself, I'm on the medical advisory board for Teleflex. There will be nothing that we talk about in today's lecture that will be problematic as it relates to that. You already heard about Dr. Scott Venable. I really appreciate being the inaugural speaker for him. I do love history. It's interesting, though, I can't really do math very well, so having a mathematician be the one that I'm speaking about is a little strange, but I very much appreciate being involved with this as the inaugural speaker. So what I want to do today is a bit ambitious, and maybe the fact that I got a little extra time will be good because I have a reasonable number of slides to talk about. I want to provide you with an overall overarching opportunity to understand disasters. Then I want to drill down a little bit on a few different areas of disaster. So we're going to talk about things that go on in the hospital and how you could even get involved in the hospital, and then a more global viewpoint of this, as well, so that you could understand if you do want to respond to disasters outside your local jurisdictions, how you can get involved in that and how important it is to understand the systems that are involved. I'd like to start a talk like this out with just a couple of questions for the audience. I did have one of these QR code things, but it didn't seem to work, so we're just going to do the old-fashioned way. The first question I'll ask is, how do clinical faculty and residents in this institution get notified in the event of a mass casualty event? Is it a paging system, personal cell phone, local newscast or alerts, social media, or I have no idea? The first question, I'd like to see who has no idea to start off with. Okay, so a few people in the room have no idea. How about paging system? Almost everybody is raising their hand for the paging system. Personal cell phone, is there a cell phone tree? A few people get through their personal cell phone. How about local newscasts or alerts? I will tell you, I have been notified by local newscast alerts about major motor vehicle crashes before I get anything from the hospital. It just comes through my local news and I'll see it on my phone and I'm like, oh, there might be something coming into my hospital, and I'll then call our EMS agency and lo and behold, they're responding to a multiple vehicle crash or something like that. So it's an interesting thing. There are a smattering people here who do not know. This is important because you want to be able to understand the system that you're working in so that you can respond appropriately and not interfere. You want to be able to help in these situations. How about this one? Where are clinicians supposed to go when notified of a mass casualty event? If they're calling in all the clinicians, where do they generally send or stage the clinicians before they go to, let's say, the trauma bay or the operating rooms or anything? Is there any particular place? Okay, so we use in our hospital, we use our cafeteria as a staging place. That will come over the pagers and we'll say, okay, there is a mass casualty event with so-and-so projected patients. Please report to the cafeteria. In the cafeteria, we'll break up into little groups. So there'll be the surgical group, there'll be the nursing group, and so on and so forth. And then we'll be able to deploy based on based on what we understand the needs are in each particular location. How about this one? Is there a central number to call for information when an MCI is called? Is there a central command number that you carry with you that you can call, or do you just call the operator if you're not really sure? So, you know, some of the problem with this is if you don't know the number and you do decide to call the operator is now going to be inundated with 10,000 people who are trying to find out the same amount of information. So understanding that maybe there needs to be a special number when you activate an emergency is important. And then the last question I have is, where in the hospital is incident command located? When you open up an incident command center in the hospital, where is it? Does anybody know? A few people know. So a few people, but the vast majority of people don't. It is important to understand where all of the information feeds into and where all the information disseminates out of when you have a disaster. So after answering all these questions for yourselves, it does appear that all of us need to work on understanding how the hospital deals with disasters. But we're going to start off just with some basic definitions and a 30,000 foot overview of some of these things. The definition of disaster, these are regular dictionary definitions: a sudden calamitous event that seriously disrupts the functioning of a community or society and causes human, material, and economic or environmental losses that exceed the community's or society's ability to cope. So pretty straightforward. When we talk about emergencies, it's a state in which normal procedures are suspended and an extraordinary measure are taken in order to avert a disaster. So you have to change your thinking when you have an emergency or a multiple patient event or a mass casualty event, which we'll get to in just a second, because you have to be able to deal with the greatest good for the greatest number of people when you have one of these situations, rather than doing things like you do every day. So in this institution and in many, many institutions, you have situations where you have multiple patient or multiple casualty events. These are events where you may have a lot of patients coming in, but they do not overwhelm the system that you have. So you have enough personnel, you have enough equipment, you have enough space, all of that type of stuff. We see this in my institution on a busy Thursday night, Friday night, Saturday night. I hear from Jeff also that this is not an unusual thing here as well to have multiple patients. This is something we could deal with, and you don't have to change your thinking necessarily. But when you have a mass casualty event, this is very different. And this is where you have any large number of casualties produced in a relatively short period of time, although COVID has taught us also that it could go on for a longer period of time, usually as a result of a single incident that exceeds traditional either EMS response, logistical support, or hospital capabilities. What you're seeing there is a bit of chaos early on, and rapidly the chaos goes away as you identify the needs that you have. But you could be in a small hospital and you get 2 patients, and that's considered a mass casualty event because you don't have the right number of personnel and support in order to deal with that. Or you could be in a bigger institution like this, or where I come from, where I could easily handle 9, 10 patients without a problem at the same time. Once we get above those numbers, then it becomes problematic. So that's the way we start with our definitions, but it's also important to recognize that disasters come in many different flavors. You might think that some flavors of disasters, which we'll go over in just a moment, do not necessarily happen in your shop. But I think COVID taught all of us that whereas we thought we would never be affected by something that was medicine, we were very much affected by this, and we ended up having to work closely with our medicine colleagues. So it's easy when you have somebody that's involved in an explosion, right? This is the Boston Marathon bombing, 3 civilian deaths, a couple of law enforcement deaths, and a lot of people injured. So, but all those injuries are going to be something that surgeons need to be involved in. Not just emergency medicine, but you need surgeons involved in all of these things. The next slide, active shooter. We all know that the numbers of active shooter events are going up over the last 2 decades. This is the Pulse nightclub, 49 deaths, 58 wounded. The deaths are things that are handled in the pre-hospital environment most of the time, and it's actually interesting when you look at it, very few people die in the hospital once they get there, but 58 wounded is a huge number of patients for anybody. And I will also say, relatively recently, if you look at some of the data that's coming out of Israel and the Ukraine, the amount of wounded that are coming out and people not being able to deal with the system is really interesting and problematic. People are coming in with tourniquets that have been on for 6 and 7 and 8 hours, and people are losing their limbs because they don't actually have a system for dealing and moving patients around. This is the Las Vegas active shooter. You see here, though, that patients were distributed to 3 different hospitals. Actually, the level 2 hospital got more patients than the level 1 trauma center based on proximity. But now let's switch our focus a little from these human causes to some man-made causes. An earthquake will provide a huge amount of fodder for surgical needs, right? So this is the Haiti earthquake from 2010. Estimated 220,000 estimated deaths, but 300,000 plus injured. Those injured are also going to have wound care issues. They're going to need amputations. They're going to need multiple surgeries, whether it's from the orthopods, the vascular surgeons, the general surgeons. Anybody who can contribute will contribute from a surgical perspective. The infectious disease and day-to-day health needs, those occur later on in a disaster, but in the early forms of a disaster, whether it's human causes or natural causes, are going to be from a need for surgical folk. Now, if you flip this to a different type of natural disaster, like a hurricane, Jeff and I have been deployed, we're deployed to Hurricane Harvey in Houston. There were 8,000 evacuees in this particular disaster, and multiple hospitals were inoperable. But it turns out you don't really need a surgeon for floods, right? You need infectious disease doctors, you need primary care physicians, but you don't necessarily need surgeons. And Jeff and I can tell you later about how much we sat around and did mostly nothing, and really wanted to go home. This is a local thing that seems to happen much more obviously on a day-to-day basis. Multiple bus crashes occurred in New Jersey. This is the one I mentioned earlier. Initial EMS dispatch for bus crash, 6:25, EMS on the scene reporting 19 souls. So you have a lot of patients who are about to inundate your trauma bay. And just to bring it home and a little bit closer, the car ramming attack here, this was 35 reported injured and 23 reported transported to the hospital here. 23 is a huge number of patients when you don't know what's going on with them, and you have to have that system involved in order to identify the staff you need and the system that you need and the equipment that you need in order to get that going. The last thing I would say is, as already mentioned, infectious disease is a problem that none of us as surgeons ever thought we were going to have to deal with. COVID upended that. Once you have a pandemic, all of a sudden, the skill set that we learn as surgeons, as trainees, as surgeons, actually come into play. Your ability to do critical care, your ability to take care of all of these patients are actually pretty unique among all of the among all the specialties. And I don't know exactly how many patients you had in this institution, but I'll tell you, all of our ICUs overflowed. In our institution, we were seeing patients in floor beds that barely had monitoring equipment. We were very active on a day-to-day basis because we didn't have an elective case schedule at that point. And we were involved in the care of a lot of COVID patients. So that totally upended our thought process about what we would be dealing with. And it also shows, though, the benefit, the value of having surgeons involved in all of these areas, because you're going to be able to provide care. Again, now looking at this, after seeing all the possibilities, this slide just breaks things down into the different types of hazards and disasters. There's natural causes. Those are the things like storms or heat waves, earthquakes, volcanic eruptions, excuse me, and then by human causes. Those are the more common ones like explosions, collisions, war, economic crisis, structural collapse. Obviously, it is much more common for surgeons to be involved, but I think I showed you that for natural causes, we are going to be beneficial to that group. Now, 30,000-foot view, just looking at earthquakes itself. This is a review of all the papers looking at earthquakes from 1930 to 2010. You can see on the bottom, well, maybe it may be a little difficult for you in the back to see it, but the global incidence of limb injury was 54% in earthquakes. The limb injury median incident per event is going to be close to 70%. You also have close to 15 to 20% of head injuries, and then torso injuries are going to be high, close to 30%. Huge numbers of injuries that are going to be taken care of by not internal medicine docs, not emergency physicians, but surgeons. So we need to be involved in all of this stuff. Here's another profile of the injuries. You can see here, there are different types of blast injuries, which I'm not going to go into right now, but you can see on the far right of that table, you have burns, crush injury, fractures, lung injuries, and inhalation injuries, all things that we do on a day-to-day basis. And you can see this is a little better image of that. So we have a role in taking care of all of these patients. Just a few stats. I'm not sure why that Philippines thing came up. But countries with the most natural disasters in 2022, it's not low and middle income countries that lead that list. Interestingly, the United States had the most natural disasters in 2022. And now that we know that there are certain natural disasters that we're going to be more involved with, it is important to recognize that surgeons have a role in planning and taking care of these patients. Does anybody know whether or not you can get earthquakes in this area?
We got one.
That's right. I knew the answer to the question. Yes, it surprised me actually. So I looked at the data, and yes, you had one in the last decade and a half.
Yeah.
It was only a 5, 5.5 on the Richter scale, but the fact of the matter is you had an earthquake. No deaths or anything like that, but people could be injured from these. So understanding the situation is really important. 10 most significant natural disasters worldwide from 1950 to 2022. You can see some cyclones and water type of emergencies, but multiple earthquakes. Earthquakes we need to be involved in because nobody else could do the job that we do. And then, unfortunately, as we all know this is from the FBI crime stats. We have an increasing number of active shooter events on a year-to-year basis since the year 2000. That's a problem. So hopefully that framed for you the need for surgeons after understanding the definitions and why we should be involved. But the next question I would ask is, are you prepared? Is everybody individually prepared? Is the hospital prepared? This is where the involvement of surgeons are important. And I like to say this to my residents: perfect preparation leads to a perfect procedure. In fact, they know it ad nauseum, and if they don't, they berate, other people berate them for not knowing the perfect procedure part. So our general surgeons behind the curve when it comes to disaster preparedness training. This is 2012. Article published or originally presented at East Trauma Conference, but preparedness education is required in emergency medicine, looking at emergency medicine versus surgery, yet such requirements are not mandated for general surgery training programs. This is actually, interestingly, something that is changing because there's an increased recognition from all the things that we were just talking about that surgeons need to be involved. EM residents have more disaster-related training than general surgery residents. These are the ACGME requirements for surgery residents. You will notice there is nothing on here that says disaster. We need to know about shock and circulatory physiology and endocrinology and burns, but there's nothing about disaster. This needs to change. One of the things that I do in my shop is I have a quarterly disaster like sort of drill with my residents. Just so they understand some of the principles of this. But this is coming down the pike from ACGME, from the surgical community. This article from 2006, J-Trauma, excuse me, not just residents, but residents graduate into attendings, and there is a general, there was a look at surgeons and their attitudes and what they believe about MCIs. Surgeons often believe that managing the medical and surgical aspects of an MCI is simply an extension of their daily activities. That's a problem. We'll talk about why there's a difference, but it's important to recognize that they are not the same thing. You have to change your attitude about how you're taking care of people. One of the things that I saw a lot during COVID was people's inability to switch their thinking from individual patient and all the effort for those individual patients to what is the greater good here and how are we going to take care of as many patients as possible. It was emotionally stressful for large numbers of people, especially nursing staff who had usual ratios of, let's say in the ICU, 1 nurse to 2 or 3 patients. Now they were taking care of 6 or 7 patients. It was emotionally stressful to them because they couldn't flip the switch to we've got to take care of everybody and not just one person anymore. In this paper, medical management of disasters and mass casualty from terrorist bombings. Again, these are man-made events that oftentimes require surgeons. The U.S. trauma community has not at all taken the lead in the development of disaster planning or education, which has largely defaulted to other medical specialties and administrative and public safety organizations, and has become more of a paper drill than a realistic guide for dealing with actual disasters. This is a problem, and it is improving, but in the early 2000s and even in the mid 2000s, there were not even disaster committees associated with the major organizations, the major trauma organizations, which usually take the lead on this. And I just submitted a paper. Actually, we looked at all of the conferences, the surgical conferences that existed between the year between the years 2000 and 2022, and found that for the most part, outside of major active shooter events, There was a paucity of disaster programming at the major trauma conferences and the ACS clinical congress. So we haven't really taken this seriously enough. One of the things they found as a prognostic factor affecting casualty outcome from terrorist bombings is the immediate presence of surgeons. You need surgeons around in order to make sure that the patients are being treated appropriately. This is the American College of Surgeons. This was a 2003 statement by the Committee on Trauma. The ACS believes that the surgical community has an obligation to participate actively in multidisciplinary planning, triage, and medical management of mass casualties after all disasters. Surgeons should provide leadership at the community, regional, and national levels in disasters involving physical trauma to casualties that will likely require surgical interventions and management. And you can see structural collapses, shootings, fires, large-scale vehicle crashes. These were happening, these statements from a small few people were happening in the early 2000s, and we're still not yet at the point where we're educating our people, our community about this. What is this one? This is an update on surgeons. This is a 2006 article. The role of a surgeon in response to mass casualty incidents is substantial in response to threats and injuries from natural, unintentional, and intentional disasters. The surgeon must take an active role in pre-event community preparation, in training, planning, and executing the response to the MCI. As if that's not enough, you're now in a trauma center, and the book that you see, or the picture of the front cover of a book that you see in front of you, for those who don't know, is the gray book. That is the current book that tells us what rules exist for trauma centers in order to remain verified. Nobody knows this actually better than Dr. Young, but the definition and requirements: a trauma surgeon from the trauma panel must be included as a member of the hospital's disaster committee and be responsible for the development of a surgical response to a mass casualty event. So it's no longer just theory. This came out in 2022, essentially saying in order to be verified as a trauma center, you need to have surgeon involvement. Another couple of things: principles of mass casualty management following terrorist disasters. These are saying the same thing. Surgeons need to be involved. And from the Boston Marathon bombing, one of the things that came out was to resist complacency. Not to be part of planning is detrimental to the care of the patients. What worked so well at the Boston Marathon bombing was that there was an excellent pre-disaster drilling and planning, and that involved all of the stakeholders. Who should run disasters? Who should run the show? This article from 2015 is actually making the argument that surgeons are lagging behind emergency physicians in taking advantage of the opportunities to run the show. We need to be more involved. So let's step off the 30,000-foot view perch and talk about hospital disaster preparedness for a moment. Understanding certain things. That number one, these events are inevitable. They're going to happen. What you have to do is understand what may happen at your particular shop, prepare and drill for it, and plan for self-sufficiencies, and make sure you have all the stakeholders involved. This is a requirement also, not just from the Committee on Trauma to deal with these things, but CMS regulations require that you have multiple aspects to disaster planning. Number one is an emergency plan. You need to develop a plan based on your risk assessment for the area. So for instance, I'll show you this in another couple of slides. Our hospital every year does something called the Hazard Vulnerability Assessment, HVA. That says, well, what is the most likely thing that is going to happen in Newark, New Jersey? The same thing that you probably do here, which is what are the most likely things that are going to occur here in Charlottesville? Since you have only had one earthquake in the last 50 years, it's unlikely that earthquakes are going to be high on your list. But maybe terrorist events are going to be higher on your list, or hurricanes, or flooding. Those are going to be higher on your list. So we'll talk about the HVA in just a minute. Policies and procedures are based on what you assess as the risks for these patients. You need a communication plan. Lots of people, this is where most places will fail. Communications never work well. From 9/11 in New York City, where EMS didn't know how to communicate with fire, and fire didn't know how to communicate with the police department. In a major city that supposedly felt that they knew how to take care of all disasters, they found communications don't work. One of the things that we identified in our hospital a number of years ago was that none of the police radios worked in our hospital. So we could not communicate with the police officers and law enforcement. Huge problem. So you need to be able to understand who the stakeholders are in order to build that resilient program for yourself. You need to train and you need to test. If you don't practice these things, just like a surgical trainee, you do repetition over and over and over again of surgical cases. You need to do this with your disaster planning and response. You can use some different types of exercises, live exercises versus tabletops, but you need to train and test these things. You need to understand where there's going to be a strain in the system, where you need to fix problems so that you have the ability to respond appropriately. Now, these are problematic and these are difficult. Why? Because it involves both monetary support as well as human support. And when these things don't happen very often, it's hard to divert money to these things, but it helps in the long run. And then there are other additional requirements, making sure there are generators and so on and so forth in the hospital so that you're not caught flat-footed. This is the general disaster cycle: preparedness, response, recovery, and mitigation. In this slide, we talk about how we identify what problems that you particularly have so you could create an emergency operations plan. Again, perfect preparation leads to a perfect procedure. You have to understand who can activate your emergency operations plan, what response procedures, including implementation of an incident command system, procedures for integrating the community-wide response, recovery strategies, and training, exercise, and plan maintenance. The things about these emergency operation plans are, you could look at this in two ways. You could say, well, I'm going to create a response for every single thing that exists out there, which is really hard to do. Or you created what's called an all hazards approach, which is a general approach to most of these incidents so that you know that you have a basic approach that could be scalable, but is comprehensive enough that's going to be dealing with a lot of these things. But you want it to be adaptable and representative of the entire community. So when you're creating one of these plans, there are some common pitfalls, which we don't have to spend a whole lot of time on. This is very specific for emergency management, but you obviously want to use accurate data and validate assumptions with testing. You want to leave some room to adapt and keep it simple and flexible. And the last thing is, you have to update this constantly. So once a year, you have to go back in and look at your vulnerabilities and make sure that you that you're ready to go for your particular area. You want to form that collaborative team to make sure that you have all the stakeholders, understands all the situations, and that's where the HVA or the hazard vulnerability assessment comes into play. You want to determine those goals and objectives, develop the plan, review and approve the plan, and implement and maintain the plan. This is not any different than the surgical plan that you're doing when you're seeing your patients. You're determining your goals and objectives, you develop those plans and review and implement. This is a copy, this is an image of our HVA, our hazard vulnerability assessment. The way it works is that it talks about probabilities, it talks about human impact, property impact, business impact, and then preparedness, internal response, and external response. You can see, I'll show you the third one. It goes through any large number of events: hurricanes, tornadoes, floods, all of this type of stuff, mass casualty events, VIP situations, infant abductions. There's a huge list of possible events. One of the things that I kind of love about our particular institution is that water failure is 67% of the time in our hospital as a risk. It's one of the, always in the top 3 in our institution. We have a building that was created, that was built in the early 1970s, and they tend to just patchwork fix things as opposed to really fix things. So nobody actually knows where all the pipes go and where all the turn-off valves are and all that stuff. When I first started at the institution around 2011, there was a sink that broke in the SICU, and it spewed hot water onto the ground for hours. Why hours? Because they couldn't figure out how to shut it off. So it was just pouring water. I was wading through water at our hospital. There's not a month that goes by in my hospital that we don't have a flood. We just had one the other day. Water started bubbling up from water fountains. Nobody could figure out why that was. It affected our pharmacy, but we're so good at this now, and our maintenance people got onto it, and we opened an incident command because it affected the pharmacy, and we didn't have the ability to get our drugs out. It was really a huge problem, but because we prepare for this, upwards of 70% of the time we believe that there's a risk for this, we're mostly ready to go. So when you have the plan in the hospital, what you want to be able to do is have these exercises. There are multiple different ways, as I mentioned, to have the exercises. The picture on the bottom is not my institution. That's actually at the Center for Domestic Preparedness. It's a place in Alabama. For those who are interested in this, it's free to go to this place and learn leadership skills in disaster preparedness for hospitals. So it's not just even people who want to deploy out in the community, but they do all of these exercises. Understanding incident command is important. You have to break it down into multiple different areas and have the right people running each of those things. So now that we're sort of done with how you create that environment, what do you do when you actually get to a situation where you have a mass casualty event? You want to change your mindset, which is instead of dealing with one patient and throwing all the resources at them, you want to do the greatest good for the greatest number of people. This starts in the pre-hospital environment and it continues to the hospital environment. You have to manage limited resources and you have to identify patients with the greatest chance of survival. We usually use triage in multiple different ways. There's a lot of data coming out now that these typical types of triage, salt and start and other types of triage groupings do not actually really work in the pre-hospital environment, and most people just do what they think is right for each person they come upon. Routine triage is using adequate resources with sufficient time and advanced training, and you triage only once. What MCI triage is with limited resources and a compressed amount of time with only basic training, and you need frequent reevaluation. And this is an example of an MCI flow from a triage perspective. There's field triage, the initial evaluation of patients, going into some more specific medical triage, and then you want to ask who's going first to the hospitals. There's evacuation triage. Then when the patient gets to the hospital, there is another triage to make sure that the patients have stayed the same or not gotten any worse, because that might change the direction that they're going in. So once you have, you're dealing with an actual response in the hospital, you've recognized it, you respond, you have to understand who your stakeholders are here. So you have a response from clinical personnel, that's physicians, nurses, trainees, et cetera. And then non-clinical, you also have to integrate into your response law enforcement. You need people to direct the flow of traffic, for instance. You need nutritional services. You need central supply. These things all need to come together in order to have a good response. And then lastly, there's administrative. You have to understand where the money is coming from. You have to be able to speak out to the community if it's a large enough event. So you have to have an administrative component to it. Here in the hospital. A couple of points as it relates to hospital response is, again, we talked about preparation and triage, patient flow. It's important to recognize that there is oftentimes a multimodal arrival modality. It could be personal vehicles, it could be the police department, it could be walk-in. Who do you think comes to the hospital first after a mass casualty event? The sickest or the least sick? The least sick. So that becomes a problem because now you have walking wounded, if at all, who show up at the doorstep of your emergency department, and you have to figure out what to do with them. If you expend all your resources on those patients who are not sick, now all of a sudden, 10 minutes later, EMS is starting to bring people in who are actually really wounded. That becomes problematic. So you need a place that you could identify where you could put your walking wounded that is separate from your treatment areas that will be needed shortly. You want to make room. Obviously, the first place is the physical space in the emergency department, but you also have to think downstream. If you have multiple patients, how are you going to utilize the operating room with them? And are you going to stop cases? Are you going to stop elective cases for a period of time? ICUs are needed, and then general beds are needed as well. So you have to make room for these patients. Bottlenecks occur, and we'll talk about that in just a minute. You have to understand command and control. Who is going to be your triage officer in the trauma bay or the emergency department? Who is going to make decisions in our incident command center? Security is important, obviously, because you never know if bad guys are going to come to your shop also. You need to control access for patients. Family members are going to start showing up and asking questions. These are very important. And then documentation as it relates to multiple patients coming in. It's very hard to do on the electronic medical record. You have to have an understanding about how you're going to name people who don't necessarily have names, whether or not that's easily transferable to the radiology department and all of these other departments. And then ultimately speaking, after all of this is over, you want to have an after action report, which is looking and dissecting down really deep dive into how you did. And you want to be honest with yourself so that you can prepare for the next one. This is just an example of what you don't want in your trauma bay or emergency department. This happens, unfortunately, more often than not. That bus crash that I showed you, I was mentioning to some people earlier that a lot of people heard about this, and all they did was flood our trauma bay. That's our trauma bay. It's a 5-bed trauma bay. We have a specific room, which we call shock trauma, which is designated as an operating room, but we could use all the bays the same way. Orthopedic surgeons showed up because all they wanted to do was splint and do their thing. Obviously you don't need them initially when these events occur. So they all got shooed out, but you need somebody who is going to be the overlord, I would say, of that emergency department. And it oftentimes has to be a surgeon or an emergency physician, but you need somebody who's going to have handle crowd control. Just a word about incident command systems. This was originally started by California Fire in order to deal with large numbers of jurisdictions coming into fires, but it has evolved into incident command both pre-hospital as well as in the hospital itself. It's an effective method to manage all organizations that respond to disasters. The key advantages of it are that it's flexible, scalable, adaptable, and sustainable. And you can see there are different chiefs that are recognized and an incident command. This needs to be started early. One of the things that we have found over the years and also in the literature is that you don't open up your incident command early enough and it becomes a problem. Some bottleneck problems, blood bank. If you have large numbers of people, where are you getting your blood from? Who's getting the blood? Is everybody going to get the same amount of blood? Are you going to run MTPs on 15, 20, 30 patients, or are you going to have to restrict that a little bit? Radiology, do you really need it in a mass casualty event? Maybe the use of ultrasound a little bit more often. Maybe you don't need chest x-rays anymore. Maybe you definitely don't need CAT scans, right? And then you have to worry about beds opening up for yourself. So you have to think about that. Documentation is an issue, as already mentioned. Perfect storm for errors as it relates to naming, blood products, medications. Solutions that have been utilized out there are pre-made packets. You have a clipboard at the bed. You want to avoid sequential numbering and write or you want to write on the patients themselves so that they carry it with them. That's very military-like. The after-action response or after-action review, I should say. Also, you start with something called a hot wash, which is almost immediately where you review some of the things that are going on. This is actually a World Health Organization document for after-action review that exists. It's actually a pretty good guide, but it's not intended to be negative or place blame. What we're looking to do is build and strengthen our response for the next time. So that was hospital, and now the last bit of slides are just the global disaster response. A lot of people in the room are oftentimes interested in going out there and trying to help other people. We saw this in a great amount in Haiti. Lots and lots of people, surgeons in particular, jumped onto a plane, found themselves in Haiti. That was probably not the right thing to do. especially when they went on their own. So we use ICS for global disaster response, and it's similar elements to all disasters. It's just in the difference in degree of disruption. But training is essential when you go out there. Well-meaning, non-trained volunteers are often not helpful, and sometimes they actually do harm. It's not conventional medical care, so you have to understand that, and damage control surgery, whether it's orthopedic surgery, general surgery, is an important component of this crisis management. The problems that you have with medical deployments that most people don't understand, especially if they're a lone person and not part of a group, is that information changes at minute to minute. So for instance, I'm part of an aeromedical disaster response team for the US government. I was originally tasked with flying to China, to Wuhan, and evacuate all the Americans there, some sick, some not sick, back to the United States. I was supposed to land in California and then pick up my next leg of flight from California. And I landed, and they're like, oh, no, the State Department's going to do that part now. You're going to stay in Travis Air Force Base, and you're going to collect the patients and then fly them around the country. So information changes all the time. You have to be able to be flexible and be able to deal with it. There was one day that I traveled for about 25 hours straight. I went from California, sunny, nice California, to San Antonio, also nice, and then I ended up in Nebraska. I did not have the right clothing because I actually had no idea I was going to Nebraska. It was snowing when I landed in Nebraska, so you have to be able to deal with some of these information changes. Now I take in my go bag something a little bit warmer, just in case I end up in some polar kind of conditions. Equipment may not show up or be non-functional. You have to be able to adapt. Roles and responsibilities blur. Again, Dr. Young will tell you, like, we are not doctors when we go out on these deployments. Like initially, like I'll set up the tents, the medical tents. I'll do all the things that need to be set up. Those are not typically things that we are comfortable doing, but we learn how to do it. You need to be able to transition from your comfort zone medical care, which is in the hospital. The days are long and the nights are even longer. You may not have the same personal care or hygiene that you can. I shouldn't say this out loud, certainly not in my hospital. I steal all the wipes right before a deployment that they wipe the patients off with, and I dump them in my bag. That's how I shower myself if I can't shower in an actual shower. There's time away from work and family. Illness and injuries can occur, and it's difficult sometimes integrating where you are. One of the things that did come out of Haiti was that there was an inadequate mass casualty knowledge that adversely affected treatment decisions. People ended up with amputations and whatnot because of that, helping or harming. So I'm going to finish this off with just disaster response. How do you get involved? There's individual training, and then if you're really interested in it, you start with presence on hospital and regional committees. I'm sure the Emergency Management Committee would be happy to have another surgeon or two on it. Well, maybe not happy, but they would tolerate it. And joining organizations, and then there are national and international organizations. This is our disaster team that Dr. Young and I are part of. We go out and do trainings together, not infrequently. We have full capabilities of an ICU, full capabilities of an operating room, and anybody who's interested, Center for Domestic Preparedness. The American College of Surgeons has a website. On their website, they have Operation Give Back, or Giving Back, I should say. That's a resource for you if you want to go out around the world to help with certain things. DMEP, Disaster Management and Emergency Preparedness, is a course that is now online, that you can do online. You don't have to find an actual class that will give you the basics of disaster management in the hospital. This is Operation Give Back. And then lastly, and I'm proud of this, I was the vice chair at the time, and now I'm the chair of the AAST Disaster Committee. We built an access point on the AAST website for resources for disaster management and preparedness. If you're ever not sure about anything, this is a great resource to utilize. There are links to almost everything that you could think of, including in-time or on-time training if you need something. And then I'm going to say thank you very much, UVA Health, for inviting me. Jeff Young, my friend, for inviting me. That was Jeff putting on a PAPR, which was the most comfortable thing in the world, as opposed to N95 masks during our deployments in Southeast California. And that's him just lounging around waiting for some other stuff to go on at one of our trainings. So I'll be happy to take any questions from you.
So one of the problems we've had here is security. We've had a couple of incidents, and we always let them, because we close off we're still closing off the main street, right? So we actually close off the main street in front of the hospital. So many of the routes that residents and nurses know to get here and park are like blocked off, or they're going to be guarded by a law enforcement officer. So how do you, and Newark is a little bit different than Charlottesville. So how do you handle that as far as getting people in, getting them parked, and all that kind of stuff?
It's a great question. One of the things that we've had problems with also is ingress and egress. How are we getting people around? We've worked with our law enforcement. We have both a security firm who works on our campus and Rutgers, which is what we're affiliated with as a university, police, to try to make sure that we have at least ingress and egress. We have identified a big parking lot, which is across the street from the hospital, that we could still block our entry into the hospital with law enforcement, but people could park across the street for it. I think part of it is engaging the stakeholders that would help you with this and saying, where do you think we could do this? And if you have to, maybe there are shuttle buses that have to shuttle people in if it's far enough away. But there's no one good answer. It's just you don't want thousands of people converging on one place at the same time. You need the EMS and police departments to be able to get in with patients.
Yeah, when we send out the page, we put the staging area on it, right? I thought we said. Anyway, okay. Any other questions?
Yeah. That was a great talk. You talk a lot about organization, what happens when the patients come into the hospital. Do they have a similar type of coordination like before this happens? Say like there's a mass, big bus, a couple of buses. Like who's in charge there? Is it police? Is it EMS? Like how do they know not to overwhelm a hospital and sending patients to the right hospital?
So that's a great question. The EMS, very similar to hospitals, have incident command. So they will set up, usually, police department are usually on the scene first of these things, but most of the time when it involves patients, they're more than happy to back away a little bit. And once EMS rolls up or fire rolls up, they will take over from that perspective. And then we have the ability, and you're supposed to have the ability in most hospitals to communicate back and forth with EMS, understanding how many patients you can take. So one of the first questions that oftentimes get relayed either through dispatch or whatnot is, okay, University Hospital, you could take how many red patients, how many yellow patients, and so on. And then that distribution is carried on, in theory, through by EMS. Now, it doesn't always work. And most of the time, the sick patients end up usually at the level 1 trauma center. And certainly if you're the only level 1 trauma center in the area, you are going to get all the patients. But that's where triage at the hospital comes into play. So even if 1,000 patients show up to you, somebody needs to be doing that initial door triage to say, you know what, not so sick. And this is where EMS or helicopter agencies may be beneficial, because now you could distribute your patients, not in the field, but once you're in the hospital or at the hospital, then you can start distributing patients to other places as almost like a secondary triage for an overwhelming number of people showing up.
Yeah, it's a funny thing. We did a mock drill at JMU in the stadium for a big disaster. And part of it was they called the ED and asked how many patients they could take. So, like, the ED was busy, like it always is. They said, yeah, we can take 3. And I was there. I was like, we're going to get them all anyway. So it's kind of stupid. And then we did a mock at JMU for an active shooter. And I presented a bunch of cases. And then we had the emergency manager for Rockingham County come up and said, Paul, so how are you going to decide where all the patients are going to go? And he goes, we're going to call every hospital in Virginia, every helicopter in Virginia, and they're all coming to you. So we said, okay, great. That's our triage plan.
It's unfortunate, as I mentioned with triage itself, it doesn't really work very well. Like it's very nice academically and it's very nice on paper, but in reality, it just doesn't work. People just go, they see somebody, they go, and they don't really wait for the scene to develop the way they should. And if you look at all these active shooter events, the vast majority of patients were evacuated very rapidly, usually within like 20 minutes. There were no more patients around. Some of that has to do with the fact that it's happened in urban centers in the United States, and they have a huge number of resources for that evacuation. But if not, people will die. This is the unfortunate nature of a mass casualty event.
That's actually one of the things that scares us the most is the Pulse nightclub. Have you been to Orlando Regional? Like it's within sight of Orlando Regional. Yeah. So that, so they had all those victims. And here, something happens at our football stadium or our event place, they're less than a mile away.
Right.
And so it's one thing that
stop it from coming.
Yeah, it's one thing that we really try to work on, at least mentally.
Jim Raymond, I'm one of the transplant surgeons. I have a comment and two questions.
Yeah.
The comment is about the fact that you have this unique water problem. Water backup. And this was my thought that anything can happen in New Jersey.
That is true. As a New Yorker who hates to say I live in New Jersey, I agree with you.
Some questions concern two areas. One, what the current status is of COVID and how you're treating approaching that. And I guess the second question was related to your training in trauma. I'm very familiar with the trauma program and where you trained. And specifically for the medical students and the residents, could you comment on how important your fellowship training is to setting your path for your first?
Yeah, great questions. The first question is how are we dealing with COVID right now? So what we do is with the state of New Jersey puts out bulletins for each county about what their percentage of COVID positivity is, and we respond when they reach a certain threshold for, let's say, limiting visitation or masking up again. We haven't been masking up until about 2 months ago. We hadn't been masking at all for patient contacts anymore. We reached the threshold level, and then we had to put out a memo for the rest of the staff. Any patient contact now is with masks again, not necessarily N95s, but masks again. So we're following these things on a week-to-week basis as the percentage goes up and goes down. I think it's just a new normal for us. And then whether or not you have to expand some of the way we did things with COVID to flu-like events or other respiratory illnesses, that's been a hot topic of debate in our emergency management and pandemic committees, trying to figure out how much we have to sort of force everybody to walk around in masks for the rest of our lives or whatnot. There's a lot of pushback nowadays, as you might imagine. So that's the way we do things. We do things based on threshold events in our general neighborhood. The second question that you had, really interesting. So I've always been involved in pre-hospital care. I worked for the largest student-run volunteer ambulance squad in the country at Binghamton University when I was a student. And I've always loved that pre-hospital environment. Just like Jeff, I'm one of the rare trauma surgeons who is a medical director for an EMS agency. It's harder and harder to find that, but because I've been involved in that, I've had a focus on some of the pre-hospital things, including disaster. And my fellowship training helped with that. There was one of my mentors, an unfortunate story, but John Pryor, who was a trauma surgeon over at Penn. We actually went to the same college, and we were very close. He unfortunately died in Iraq, but he was very much also into pre-hospital environment, and he pushed me in and mentored me in ways that allowed me to develop my standing in the pre-hospital environment and disaster. So he introduced me to people. He got me involved in some of the journals that exist in the pre-hospital environment and EMS. So that's really how I got it. But if it wasn't for him, I probably still would have had that bug just from growing up in that environment. And now I try to identify, I think we have a lot of people on the AAST disaster committee now who are young and really interested in pre-hospital and disaster response. There are people who are even talking about, there's actually a push now to create a new board certification in pre-hospital and disaster medicine that is not directly through emergency medicine, because emergency medicine has really clamped down on who could be involved in that, which is unfortunate. They like to take ownership over this, and I think it's time we change that a little bit. Yeah.
I loved your talk, and I was wondering, when we're talking about this, what is your view about for instance, a hospital like this, a residency program? We have a ton of people in different levels of training that in a setting where you are limited in resources might be helpful. But of course, if you don't do this correctly, it might not be helpful at all. It might be deleterious. And so how robust should be the preparedness part for residency and fellows? And even as part of the trauma and critical care world, I will say that in general, the Department of Surgery, all the surgeons available might not know exactly how are we going to help and participate. So how robust the department and the residency, for instance, preparedness and drilling and being ready should be, if we don't start by our home turf.
So some of this is going to be dictated by the ACGME at one point in terms of disaster preparedness. The SCORE curriculum is being now written. There's a disaster component to the SCORE curriculum that is being developed right now. So that will take care of general surgery training. But I would say as people are getting closer and closer to the trauma community, we have our fellows. I bring my fellow. So I run the emergency. I'm the physician in charge of the emergency management committee. I bring my fellows to our meetings. We also have a trauma specific grand rounds once a week. Every 3 months or so, I'll do a disaster triage kind of thing. I actually just put up a huge picture of our trauma bay, and we have sticky pad things, and we'll have, these are the patients who came in, how do you distribute them? And then we have somebody who's a team leader and somebody who is supposed to communicate with the incident command and so on and so forth. That's a little bit more aggressive than most places I've heard of, but I think you have to start with education. And also understanding that it's not the worst thing in the world if our trainees, especially our fellows, go out with EMS and understand how EMS works. I send my fellows both onto my helicopter and on our ground units at least once every 6 months so that they have an understanding how patients are evaluated in the field and how they're brought back to us. We also liberally encourage people to hear the emergency physicians when they're doing disaster training. We offer that up, whether they do it or not, I can't say. But I think it starts with education and then involvement and making people excited over this. I mean, you can tell I think I'm a bit excited over this. I enjoy this tremendously. And there's an enthusiasm for it, I think, that that can be generated to our trainees. And then as you build their acumen in it, they're going to graduate into attendings, and they're going to have that basic understanding and knowledge, and then they'll be more facile with this.
Dr. Fox, thank you so much for that talk. It's very helpful. I'm in the Navy. I did my general surgery training at Naval Medical Center San Diego, and then spent the last year with the Marines. So I've done a ton of exercises in mass casualty response. And what I have found, either whether it was happening to myself or someone else, is that in these situations, whether it's in the hospital or out in the field, the surgeon often gets misplaced in that they get pulled to the front to do triage, or they're in the ED doing simple ED procedures like putting in chest tubes. How do you feel the surgeon should kind of approach these situations, and where should he or she place themselves to be used appropriately?
You know, I think we as surgeons have a difficult time sometimes handing the ownership of certain things over to other people. We're the best at it. We're by no means was I trying to say in this talk, and I hope nobody walks away with this, that emergency physicians don't have a right to be part of this. This needs to be a multidisciplinary group. And there are some places, and I think we talked about this last night even, the British folk don't even allow the surgeons in the trauma bay, right? So as they're deployed, because they want them doing what the trauma surgeons are supposed to be doing and not, or as surgeons, what they're supposed to be doing and not necessarily, it's not beneath them, it's just they're utilizing their skill set in an area that needs to be done. Now, obviously, that requires an understanding of who you have and the skill set that you have. Not all surgeons, I think most surgeons, as you develop your skills through your residency training and fellowship, have a leadership skill set that is different than almost any specialty. Like, I'm biased, but I think it is. I think it's different. And you have, if you've done a rotation in trauma and you've run a trauma bay, you have a skill set that's different than almost every other specialty. But we also need to recognize that if you don't have enough people, we need to be in a place where we're going to be operating on the patients that need to be operated on. So there needs to be, unfortunately, a surgeon in incident command to understand what your numbers are so that you can distribute people appropriately. I think that's where you have to sort of waste a trauma surgeon from operating so that they can build that environment. But as you said, the pre-hospital environment is certainly chaotic, and it really creates a problem for this. I don't know if you know Steve Rush, who ran the PJs for a while. He 100% believes that we should go away from the classic type of triage because it never works in the field and whatnot. So I think that understanding what your resources are and then distributing them appropriately. If you have enough resources, then I don't think there's any problem with the surgeon doing triage in the beginning because they understand the surgical problems and pathologies that are there. But at one point, you have to rely on some other people to do it and move the surgeons to where they're really going to be helpful, which is operating.
Thank you, Dr. Fox. Looking outside of surgery specifically, what are some ways to be successful in getting an entire institution? I mean, the big challenge for any emergency planner, whatever their day-to-day role is, getting folks to spend time and treasure on basically buying an insurance policy for something that probability-wise is not going to happen.
Super challenging. I don't have a great answer other than making sure that you involve all the stakeholders. Like, one of the big problems that we have in our shop, for instance, is we have never brought our disaster drills past the emergency department, right? How do you stop an operating room during the day to bring other patients there? Or how do you move the ICU patients around and so on and so forth? What we've been developing in our shop, based on speaking with some other people, is doing it as a tabletop, but bringing all the other people involved. And if you could do that, it's limited resource, just some time, and at least you know where the problems are. That's a start, knowing where the problems are. Unfortunately, you can't fix this easily in general because people don't want to spend the money on it. And if you look at after action reports from most incidents, as you probably know, it's the same problems over and over and over again. It's hard to fix completely.
All right. Well, thank you, Adam. I have a nice gift for you.
Thank you very much.
And
Again,
everyone,
thank you
just
for
remember,
having
we
me.
moved up chicken conference to today at 11:30 at dining conference room so that Adam can go and see how we do things, and everyone is welcome. All right, thank you.
Chicken companies.
Thank you. Thank you for having me.
Usually on Fridays, the trauma service has their
I don't know where he goes.